fourth installment of the ICRR webinar series. And this time we'll be talking about addressing patients' mental health. So I'd like to acknowledge Professor Sherry Grace and Dr. Karam Turkadawi, the ICRR co-chairs, and also Dr. Gabriela Gysi, who's the chair of the user subcommittee. So just to remind everyone, this session is going to be recorded and it's going to be available in the ICCPR website. It's also being transcribed. There's captions uh, uh, going on at the minute. So welcome to everyone. So this is all our participating sites for the International Cardiac Rehab Registry as of October 2024. And my name is Dr. Dion Candelaria. I'm a postdoctoral research fellow from the University of Sydney. I'm the secretary of the ICCPR and also the quality improvement lead of the user subcommittee of ICRR. So I'll be your chair for today's session. And before I give you a bit of rundown of the session, I'd just like to remind everyone that initiatives about quality improvements available at our website. You can use the QR code to learn more about our initiatives and also to remind everyone that this is, as I've said, the fourth topic for our quality improvement webinars. We started in 2023, engaging women in cardiac rehab. We talked about barriers and adherence. And early in 2024, we talked about information needs and knowledge. And all of these topics are suggested by the members and the user and the data stewards of the registry. And for this time, the suggestion was to talk about addressing patients' mental health. And you will have seen, you would have received the reports that were sent by Sophia about the summary of your own data and also benchmarked against the average of all of the sites. So in the future, let us know what you want to focus on. I think there were suggestions about return to work, but this is going to be in early 2025. So do email us for your suggestions. So for today's webinar, I'll give a bit of overview of why depression, stress, and quality of life are important to address in cardiac rehab. And then I'll talk about some high-level performance of your sites, average performance, which overall is great. Just so to let you know and to reiterate the good job that you are doing. And then we'll hear from Jonathan Gallagher, our guest speaker for today's webinar about improving mental health outcomes in cardiac rehab. A very experienced senior psychologist in the cardiac rehab space. And then there will be opportunities for discussion or question and answer towards the end. And then I'll be reminding of the upcoming QI chat. All right, so without further ado, why is mental health important to assess in cardiac rehab? And I'm sure Jonathan would have more reasons to say, but evidence say that post-MI depression is associated with increased risk of all-cause mortality, cardiac mortality, cardiovascular events. And both a previous diagnosis and present self-reported symptoms of anxiety and depression are associated with increased risk of death and recurrent cardiovascular events in adults with first-time myocardial infarction. So I guess what this point is saying is that it's twofold. It's important to assess patients as they come in or as they get referred to cardiac rehab programs, but at the same time, it's also important to make sure that we have a look at the patient's past medical history to identify those with history of depression. Also, practitioners have noted that cardiac rehab patients often have complex psychological needs, but the confidence of the practitioners in discussing and in supporting these psychological concerns varies. So not understandably so, I guess, not all of the clinicians have the same kind of confidence and competency to help patients with psychological needs. Therefore, there has to be a referral pathways for clinicians and professionals with the right expertise and experience to help support patients with complex psychological needs. So I think those are the kind of the three main points that I wanna share, to just to set the scene. Um, Also, I guess I'm gonna throw it in is uh, it, previously patients with depression or depressive symptoms are known to not complete their programs as much, but we recently know from studies that in fact those patients with depressive symptoms have a lot more to gain and they do attend and complete cardiac rehab programs. So that is one thing that that we learned from longitudinal studies and from big cohort studies uh, that is, I guess, changed our thinking because yeah, initially we thought patients with mental health concerns drop out more, but apparently not. So uh, so that's that. Now, just to remind you, the depressive symptom screen in ICRR is measured using the PHQ-2. So there are only two questions. A, little interest or pleasure in doing things, and B, feeling down or depressed or hopeless. And the response options are not at all, several days, more than half of the days, and nearly every day. And you sum the scores. Anything more than or equal to 3 would indicate a positive screen and would then require a full assessment. So in the coming slide, those that are positive screen would have a score of 3 or more in PHQ-2. So this is the performance of your site. As I've said, you would have received your own site, and for confidentiality, we've indicated the sites by letter. And overall, from a positive screen rate of about 10% pre-program, uh, it's reduced to 2.5 post. So that's minus 8.3% on the whole. So this is all of the patients that screened positive pre and also with post data. So patients without with missing one, either pre or post, would not be included in these numbers. And as you can see, there's good negative change, mostly pre to post, uh, but I guess what we don't know uh, is the effect of time, is the effect of recovery. Are they kind of getting better on their own, or whether this is due to interventions, due to what you did when you screened them and you positive and you intervened. So I guess that's another interesting thing for us to kind of tease out from these data sets. But overall, I guess this is really good. Um, Now we also wanted to correlate that, I guess, with the knowledge on stress management at post. And again, 86.7% have good knowledge on stress management. So I think that's also a kudos to the sites. Um, and the range is, I guess, P is around 60%, but on the whole, there's a lot of sites on the 90s. So that's really good. And just a reminder, this is your variable 25 on your data dictionary if you wanna check. Um, the last variable that we want to have a look is the quality of life. So change in quality of life. So we made it super streamlined, 0 to 10, 10 being, really good quality of life. And from, oops, sorry. So from 5.9 pre, 7.7 PO. So there's a change of 1.7 points on the ladder. So so that is a clinically meaningful improvement. So again, you know, continue doing what you're doing because it's really making a difference in your patients' quality of life. This is just a little reminder for everyone that you can see your program's quality of life performance in real time and on demand. There's a dashboard, patient-related outcomes report, and you can generate that yourselves. It would look something like this. Your own site on the far left, and on kind of the a baby blue color, and then on the darker blue is all the sites. So I think from this bar graph, you can benchmark yourself, your own performance against the average of all of the sites. And just a kudos to our highest performing sites. So again, we defined highest performing sites as the greatest reduction of positive screens of depression pre to post. So we have sites from the Institute of Physical Medicine and Rehab in India. Congratulations. Center Medical Ibrahim Mamadou Wayne Wani from Senegal, and Taba Heart Institute from Pakistan. So congratulations to our guests. They're the top 3 kind of top performing sites. So congratulations. Now, yeah, without further ado, let me introduce our guest speaker. We're very lucky to have Jonathan Gallagher from Ireland. So Jonathan is a senior psychologist in the Department of Cardiology, specifically in cardiac rehabilitation at Beaumont Hospital in Dublin, Ireland. So Beaumont Hospital's Cardiac Rehab Center is internationally accredited both by AACVPR and ESC, the European Society of Cardiology. So I'm going to stop my share and Jonathan, you can take over. Welcome.
Thanks a lot, Dana. Thanks for that. Just make sure my screen can be seen. Can people see my screen there?
Yeah, we can see your screen.
Awesome. Okay.
Sophia, can you spotlight Jonathan?
Yeah, I can do that.
Thank you.
So thanks very much for having me. I'm delighted to attend this session. I'll get straight into it, just in terms of managing the time. What I'm hoping to convey as part of the presentation is that people will learn hands-on strategies that are focused on improving the cardiac rehab outcomes that are related to stress, depression, and quality of life, and that we can do this during the cardiac rehab program itself. I'm going to specifically focus on strategies low resource. Everybody has access easily to mental health professionals. So it's important that we're able to assist in improving patients' mental health during cardiac rehab. And hopefully by the end of the session, you'll be able to leave with at least one actionable item that you can implement in your own cardiac rehab site regarding improving stress management or indeed mood management. Okay. So just a few words, I guess, on stress to begin with. We know that higher levels of stress are linked with worse cardiovascular health. In terms of the famous InterHeart study, we know that stress independently has an impact on mortality and morbidity. And it's on a par with other risk factors that we know, like hypertension, smoking, and diabetes. And while in some respects, it's difficult to tease apart stress from its impact on the behavioral pathway, it does seem that once we account for the other risk factors that stress impacts, there's still a direct link. It doesn't fully account for that. That's important. And in terms of how stress is defined, particularly chronic stress, the prevalence rates for this in cardiac rehab, and cardiac patients rather, are anywhere between 30 and 60%. And if you ask patients themselves what they believe caused their own cardiac event, particularly for MI patients, often that figure is even higher. So what are the mechanisms? How does stress have its impact? Well, it's actually quite complicated, but in pretty straightforward terms, what we know that the direct impact seems to be down to chronic elevations in stress hormones, like adrenaline and cortisol, that ultimately lead to higher levels of blood pressure, inflammation, and higher levels of circulating lipids, and even an increased tendency of the blood to clot. But we also know stress has an indirect impact on lifestyle factors, particularly in terms of nutrition, sleep, and exercise. And I'm sure we all know from our personal lives that when stress is ongoing and cumulative, managing our diet and our sleep and exercise is a little bit tougher. So how would we define stress? This is a space where there have been quite a lot of definitions, but probably the one that's most well known is this idea of a mismatch between the demands and our perceived ability to cope. It's when we feel that we've much more on our plate than we can cope with on an ongoing basis. And if that's persistent, this can result in a state of mental or emotional strain. And stress has also been conceptualized as the rate of wear and tear in the body, because there's good physiological evidence that chronic stress can accelerate premature cellular aging. How stress can result, it can be as a result of stressful life events. There's hardly one greater than a major deterioration in your health, but probably more importantly, chronic daily stressors that we all face. Persistent stress that can result from work challenges, home, finances, relationships, or indeed our health. And health can be your cardiovascular health or other comorbidities you might have, but it can even be viewed as something like depression. And high perceived levels of stress are critical because it's really in the eye of the beholder. The type of stress that is most likely to impact somebody's cardiovascular health on an individual basis is when it's ongoing, it's cumulative. We feel it's out of our control. And crucially, we feel we have very little control over the outcome. And if we think for a second about the patients that we see, many from low resource settings, if they live daily in terms of social challenges and financial adversity, their perceived control is undermined from the beginning. So I'm going to linger on this slide for a second. I would imagine everybody on the call would be well acquainted with the fight or flight response, or the fight, flight, or freeze response. And the reason I'm lingering on this is because it's really important, I find, to be able to articulate this to our patients in a way that it's engaging, but actually makes sense to them. And the reason for that is that when patients have a good sense as to the fight or flight response and why we have it, any strategies that we recommend or teach them during cardiac rehab, they're much more likely to bed in, to take hold. So our body's fight or flight response is just this automatic reflex for helping us deal with threats and demands. And a variety of changes occur. We've mentioned it in the mechanism sections there, blood pressure and heart rate and so forth. But when threat is detected, this automatic response kicks in and makes us very vigilant to threat, and it results in an immediate reaction. And if you look at this graph in front of you there, hopefully you can all see it. The blue line represents a healthy stress response. It kicks in quickly, it does its job, and then it recovers quickly as well when we set the baseline. The line above it, though, the red line, represents a chronic stress response that over time might end up being impaired. And this is when our stress response kicks in, but instead of actually coming down quickly and us recovering, is we can, as a result of chronic stress, have our stress response jacked up repeatedly that it never fully turns off. And this is problematic because it can affect things like blood pressure, diabetes, even our cholesterol levels. But other systems that are required for ongoing maintenance, they take a hit for longer than they should. And those three green arrows there, it's just merely to bring our attention to the fact that there are things that we can do, at the very least, that can accelerate the recovery process. And again, our stress response can thankfully be switched off. So in terms of stress management training, there's usually, this has been well studied, there's quite a good evidence base behind it. And there are several proven approaches to stress reduction. Cognitive behavioral therapy or cognitive behavioral stress management has been shown to be quite effective. That's not always available. And relaxation techniques such as meditation, yoga, and mindfulness, which are interventions in their own right, they've also been shown to be effective. And exercise, we know, is a powerful stress reducer. When somebody has access to stress management training, usually it targets 3 different areas. The thoughts that we have that are perpetuating our stress response, potentially, the stress-related physiological responses, what ramps up our physiological arousal, and the external sources of stress, the stressors themselves. Is there anything that we can do to minimize the demands associated with that? And an important principle is that the intervention for managing stress should match the actual stressor. So if I was to give you an example, if somebody was prescribed meditation in an effort to help manage their blood pressure, this could well be effective, but if the main source of their stress is marital difficulties or relationship stress, it's likely to be insufficient and they may need specialist intervention there. The other point I wanted to make there is that stress is often a signpost for something important that we need to listen to. There are many of our patients that are in stressful scenarios, maybe it's a work situation, and the most stress relieving aspect for them will be find a way to move their jobs, which is very difficult for some of our patients. So I'm going to get into some strategies for you to consider employing or for your patients to employ during cardiac rehab. And I should say before I proceed that some of the strategies that I'm going to lead in with in terms of managing stress, they've also been shown to dovetail to help manage depressed mood or at least depressive symptoms. So the first strategy is not so much a strategy as it is a guiding principle. We've already touched on perceived lack of control and how this is associated with stress, depression, and anxiety. And our sense of control might be affected in one or multiple areas of our life. It could be at home, our relationships, our finances, or the main topic that we tend to see with our patients would be their health. And while this can be quite overwhelming if it's in multiple areas, you do tend to see that if somebody achieves a sense of control over one important area, in this case, their health, it tends to have a natural spillover effect on other areas and build their confidence. So I guess what I'm saying here is for us as a principle, to take every opportunity during cardiac rehab to help patients exert control over their physical and mental health, because there's several opportunities for that. And that barely visible picture that I have there on the screen is a snowball gathering pace. And it's just to emphasize that the small changes, they do operate iteratively. They build and gather momentum over time. So relaxation techniques, and these sound more complicated than they actually are, but the basic principle is that everybody should be able to achieve a sense of deep physical relaxation. And this is important health benefits, because if we are able to train our parasympathetic nervous system, what will happen is it will elicit the relaxation response. And this is really important because this switches our body from the fight or flight response into the rest and digest response. But it takes a little bit longer for it to kick in. And regular relaxing activities like, going for a meal, watching TV, listening to music, these are very good and very helpful. But we need something on a different level, and that's where relaxation techniques come in. There are very many relaxation techniques out there that have been studied. They do tend to gather into about 6 main categories. And the ones that I have there, they're abbreviated, will be progressive muscular relaxation, deep breathing or diaphragmatic breathing, meditation, mindfulness, yoga, and imagery or visualization. There are others, and they have similarities, but they're mainly these factors that have these 6 areas that have been studied. And any one of these techniques will work for anybody in terms of achieving deep physical relaxation. But the key thing is that regularity of practice is the important aspect. And what we want to do, I'm sure now, if you look at the picture at the bottom right of the screen, we've all been on fire training during work, I'm sure, or in college. And one of the key principles is that you want to starve the fire, in this case, the stress fire, of oxygen. And what happens is when you train the parasympathetic nervous system, you bring down the overall level of physiological arousal. And this means if you like, what I tell patients, their relaxation nerves become more dominant and we're better able to switch stress off. So reducing our arousal level starves the stress fire of oxygen. And we can do this on a regular basis. Again, I would say that everybody on the call is familiar with diaphragmatic breathing. I'm going to linger on this, however, for a little bit. I would view this as the most important relaxation technique in cardiac rehab in terms of managing stress, primarily because there are high levels of adherence to it. I've been lucky enough to do other stress management training courses and Harvard Medical School and even just more local courses. And the reason I'm mentioning that is that they will all say that diaphragmatic breathing is the technique that patients are most likely to do when they're well out of cardiac rehab. We know that it gives immediate feedback in the body. We know that it lowers physiological and psychological stress. It decreases our levels of adrenaline and cortisol, and it can have an impact on our blood pressure as well. There's also some evidence that it improves exercise tolerance, which is particularly relevant in cardiac rehab. Rather than give patients an audio clip or a video clip, what I do during cardiac rehab is I give them supervised instruction. I usually do this in a group setting with feedback. And importantly, I give them cues or encourage them to use cues or reminders to weave this into their day-to-day. Because what you don't want is you don't want somebody who needs to be able to use a relaxation technique months after having completed cardiac rehab, and they're thinking back as to what they were taught. So if you give supervised instruction with feedback on the technique, do this a few times, and they can use devices like Fitbits on their phone to encourage them to breathe. But once they get their technique right, they can do this rather invisibly as a result of throughout their day-to-day. And I'll even go as far as to give patients blue dots to distribute seamlessly in their environment. They're quite subtle, just to remind them to accumulate sufficient breathing exercises throughout the day. So I find patients they're well able to introduce this into their day, no matter how time pressured they are. And they can use up all the dead time spent in queues or in traffic. But it allows them to actually train their parasympathetic nervous system, if you like, to become more dominant, because the breathing pattern becomes slow, deeper, quieter, and more regular. And I've used the phrase there, multi-purpose, because if your patients are quite well versed in the stress response, and they have a technique that's quite immediate and that can take 1 minute per time, like diaphragmatic breathing, it's something that they can do regularly with reminders. But also it has functions for helping them to manage sleep and in terms of manage chest pain if they have been cleared and they have, for example, ischemia due to stress. This is something that they can employ to take control over their health. Another relaxation technique which you may have heard of is progressive muscular relaxation. And this isn't the only technique that you would teach patients, but it's something that's very physically based. For patients, they view it as very practical. They get immediate physiological feedback after the 15 or 20 minutes doing it. And it's something that can be incorporated into other aspects of treatment during cardiac rehab. It sounds complicated if you're not familiar with it, but it's really very basic. And it involves systematically tensing and relaxing our major muscles, to do this at a pace much slower than I'm talking right now, and to do it over a period of time, that each local experience of relaxation will coalesce into an overall relaxation response. When that does, our heart rate comes down, our blood pressure comes down, our immune system gets kicked back into gear rather than suppressed. And it reduces muscular tension and physiological arousal levels. For those of our patients with sleep difficulties, if they were to engage in cognitive behavior therapy for insomnia, which we'll talk about a little bit later, this is one of the key aspects for managing sleep as part of that treatment protocol. And relaxation techniques like PMR, they're particularly effective when combined with other relaxation techniques. So exercise is something I probably don't need to speak too much about for the audience that we have here. But if you think about it, the clue is in the name. For exercise, the whole idea of the stress response, that it was designed to be followed by an explosion of vigorous muscular activity. So if we're experiencing chronic stress, and for whatever reason we're exercising regularly, what's happening is there's a natural symmetry to that process, where stress hormones are being burnt off, tension's being leached out of your muscles. And it also helps clear our mind and improve our mood and our self-esteem. As I'll touch on it a bit later, exercise on a regular basis is a potent treatment for depression. And in patients living with heart disease, it's been shown to be as effective as antidepressants for mild to moderate depression. So sleep is crucial, and particularly for our cardiovascular health. And how often have we been in a situation where people are under stress, but the next day, having slept on it, they feel much better? And there's a truth in that old wives' tale. So it's essential for our cardiovascular health, but it's also a firm foundation for managing stress. And it's important that we give ourselves the opportunity for at least 7 hours sleep per night. And for many people, getting insufficient sleep can be down to just not getting to bed in time. And when we have insufficient sleep, despite perhaps the opportunity, it's usually our REM sleep is the first to go. Our rapid eye movement sleep, and this is part of the sleep cycle that one of its functions to help reset our emotions to keep them more stable. We also know that sleep is tied to cardiovascular risk factors like blood pressure. And for people that have an improvement in depression during cardiac rehab, if they have residual insomnia, despite an improvement in depression, they're more likely to have a relapse. The good news is that even 40 minutes of an improvement in your sleep has been shown to lead to improvements in cardiovascular risk factors. And I want to say a quick thing about sleep hygiene. Sleep hygiene is very beneficial. As part of the pack that I'm going to leave the participants on the call, I'm going to give you an updated sleep hygiene that involves 15 strategies that are evidence-based for managing sleep. But it's important not to confuse it with cognitive behavior therapy for insomnia. It's necessary, but it's not sufficient for people who have chronic insomnia. And chronic insomnia is defined as somebody who's persistent sleep difficulties, either going to sleep, being roused during the night, or waking up early for at least 3 times a week, at least for 3 months. And it has a major impact on their day-to-day functioning. Sleep hygiene is not going to have a significant impact on that. But cognitive behavioral therapy will. That is cognitive behavioral therapy for insomnia, CBTI. Now, I don't have any any commercial association with any of these companies, but CBTI Coach and Sleepio are 2 online treatment protocols for delivering CBT for insomnia. And they've been shown to be very effective. And there's also an opportunity to access these free for our patients. And that's something I can provide in the literature that I leave. I should say briefly, CBTI for insomnia, it works as effectively as medication for sleep, but it doesn't have any of the safety concerns. The effect is more durable. It lasts up to 10 years. And the effectiveness rate is anywhere between 70 and 80%. So again, we need to know what our stress triggers are if we're to manage stress or encourage our patients to do so. We all have buttons that we can push. And this is different for everybody, but it's important to be aware of this. This is the role that we play in terms of preparing ourselves for stress management, making it more predictable. So when we know our triggers, or our patients know their triggers in advance, we can be better prepared for their future. And this introduces predictability and, again, a sense of control. When we're aware of our triggers, we're reminded we have a choice over our response. Can I change the stressor? Frequently we can't. Can I remove myself from the situation? That's possible sometimes. But we can always change our reaction and turn it into a response. Negative self-talk. So this is something that is relevant for both stress and depression, but it's important to know that our thoughts are stressors that our bodies respond to. And we've up to 80,000 thoughts a day, and most of these thoughts are the same ones we had yesterday. And inadvertently, we can frequently put pressure on ourselves by the way we talk to ourselves during stress. We'll often chide ourselves without realizing for things we should and shouldn't be doing. And patients during cardiac rehab, this is quite frequent. So we would encourage you to get your patients to pay attention to their self-talk and to stop shoulds in their tracks. And a simple rule of thumb will be not to say anything to yourself or to your patients that they wouldn't say to a loved one. And again, to practice positive self-talk whenever possible. We say, just to emphasize that aspect of choice, we say in psychology that you're not responsible for your first thought, but you are for your second. And again, this is an area, my eye is drawn to the icon at the top. This is an area where we can inadvertently add petrol to the flames instead of starving that fire of oxygen that I mentioned earlier. So in terms of social connection, this is crucial both for managing stress and also managing low mood. And essentially, positive social contacts are critical for heart health. And it's been shown that the effect of poor social health on mortality, all-cause mortality, has been estimated to equal 15 cigarettes per day. And that people that were socially isolated are 30% more likely to have coronary artery disease. And when it's established, these people who are socially isolated are twice as likely to die from it. So it's really important that we leverage the social element of cardiac rehab, those different layers of social support, and to encourage our patients to prioritize this as if it was medication. And some straightforward strategies to do this is that for people to be encouraged to lean on their primary relationship. It may or may not be a spouse, somebody you trust that you'd view as a confidant. Maybe it could be as simple as joining a group with a shared interest or taking part in community activity. Or maybe your local heart foundation might have a patient support network like we do in the Irish Heart Foundation. Or it could be simply just calling old friends and colleagues and relatives. With these different layers of support, they've been shown to be effective in maintaining our mood and to managing stress. But this is a very simple one, but in terms of spending time in nature, you may do this routinely, but it's interesting to say that there are actually some health benefits for this. It's been demonstrated that regular time spent in nature, what they call raw nature, as opposed to just your local park, but that's beneficial too, reduces stress, lowers cortisol, and even lowers inflammation. And there have been multiple studies, including randomized controlled trials, that have shown that this practice is associated with a 5-point drop in systolic blood pressure, an increase of 900 steps, and a reduction in both depression and anxiety symptoms. And again, regular time spent in nature, I know they call it an exercise prescription in some territories, that it's likely to be beneficial for both for your cardiovascular risk and to improve quality of life. Any amount that you spend is beneficial, but the recommended dose would be at least 2 hours accumulated over the course of the week. So in terms of managing worry as one aspect of stress, as it's often been said, whatever you track, you have more control over. And we already know this from things like food diaries, calculating our fruit and veg and the amount of steps that we take. This influences our behavior. But we can also do something similar with our worries. Everybody worries, but often the worry that we have is quite inefficient in that it's free-floating. There's no purpose to it. And it maintains a kind of a low-grade anxiety that gives the sense perhaps that we feel prepared for any of the worst case scenarios that occur. But unfortunately, this does nothing to manage stress. And it's important that as much as possible, we can compress the amount of time that we worry, if this is something that affects you, into a smaller amount of the day. And this is where worry scheduling comes in. It's the idea of being able to take note of your worries. It could be in your phone or a pen and paper. You can do this quite discreetly. To get a sense as to the categories of worries that are likely to affect you. They're usually to do with family, health, finances, relationships, and so forth. And to postpone that worry into a section of the day that you've scheduled, where you will actively worry for that period of time, so that it doesn't take over the whole day. And it means the limited worry time that you have, you use it more effectively. And what people tend to see is that their overall level of worry tends to reduce. They're better able to postpone it to that time. They're better able to give themselves permission not to think about it now. And when the time comes to practice that technique, what they'll often find is the worries aren't nearly as compelling. But it's something that's been shown to help patients get a sense of control over their worries from that aspect of stress.
5 minutes, Jonathan. Sorry to interrupt.
Okay, thanks for that. So in terms of another technique that I'm going to just rush through basically is practicing gratitude. This has been shown to be beneficial in terms of managing sleep as well. But also, even if we're quite pessimistic by nature, we can learn optimism to a certain degree. And an interesting strategy that we can use before the close of the day, before going to bed, is to list 3 things that you're grateful for your patients. And for example, was there something that day that went better than expected? Something that made them smile or feel good today? Or did they make someone smile today? And there's interesting evidence to show that if this is practiced regularly over time, and there's actually a cardiovascular benefit to this, as well as to some degree improving sleep. So in terms of depression, I'm going to switch focus to that now. What is depression? Well, we all have our ups and downs, as you know, but when we experience depression in a clinical basis, it's different. It's when you're feeling really down, that's persistent, sad, and depressed mood. And this would occur most of the day, for most days of the week, for at least a 2-week period. And while clinical depression can sometimes be associated with chronic stress, and there are other factors that make it quite individual. And when depressed mood becomes so severe that we feel we can no longer cope, that's when we need to seek help or get our patients to seek help. And it's important for our patients to know that it's not caused by personal weakness. It's usually a whole panoply of factors that lead to people feeling depressed. So as Dion touched on earlier, with the PHQ-2, the first 2 symptoms there are sad or irritable mood, or loss of interest and motivation. They're the cardinal symptoms of depressed mood. But we need at least 5 of these symptoms in terms of a change in appetite or weight, insomnia or excessive sleeping, and physical slowing down of the body or agitation or restlessness, and continued fatigue or loss of energy, feelings of guilt, diminished concentration, and increasing thoughts of death or suicide. The mechanisms, I won't linger on this for too long. They're quite similar to those that we touched on in terms of managing stress. But there's a particular focus in patients suffering with depression on the behavioral pathway. These patients, unfortunately, they're less likely to adhere to their medications. They may be more likely sometimes to attend cardiac rehab, but they're certainly more likely to drop out. At least a lot of the evidence has suggested that. And indeed, social isolation can compound those feelings of depressed mood. In terms of your patients to look out for, the patients that are increased risk of persistent depression are those, I think Dion has already mentioned this, have already got a history of anxiety or depression in their medical charts. They're living alone or socially isolated. They're younger. They tend to be under 55 years of age. They regularly use substances, licit and illicit. And they may have had a recent bereavement or job loss or financial stress. So these are the patients that we tend to look out for in particular, and they may need intensified support during cardiac rehab. From the point of view of people's beliefs about illness and how they relate to depressed mood, again, we know a lowered sense of control over your illness makes you more likely to experience depressed mood. Patients that have a chronic view, and this is a tricky one to articulate because we need our patients to understand that they have a chronic condition in order for them to be amenable to taking treatment on an ongoing basis. But learning that you have a chronic condition is inherently distressing. And we're a bit more likely to gravitate towards an acute model. So there's kind of a complex interplay between those. And our patients that feel that their illness has a greater consequence in their lives at work or at home, these are patients that are more likely to have persistent depressed mood. So again, I touched on this earlier. I won't linger on it for too long. Exercise has shown comparable benefits to antidepressants in both mild to moderate depression. And it reduces the depression burden. So symptoms of depression that are experienced by patients during cardiac rehab, patients with MI, bypass, or heart failure, we know that exercise training attenuates those symptoms. So just to finish up, in terms of some pretty straightforward strategies that we can encourage all our patients to employ during cardiac rehab, is at the very least encourage the achievement of the maximum dose possible of cardiac rehab exercise sessions. We already know this in terms of exercise capacity and outcome. But the more sessions that they attend, the more exposure they have to other treatment elements, and the more likely their mood is to improve. And even where possible, to encourage patients to exercise, for example, even just walking on the non-cardiac rehab days. For your patients that are feeling low and depressed, it's vitally important that they schedule positive activities into each day. Any small thing in their day that introduces a sense of enjoyment, achievement, it could be just washing the dishes even, or even their sense of independence, like collecting their medications themselves from the pharmacist. Things like daily excursions or hobbies, dining out, these things seem very small, but when your mood is low, they're vital for helping scaffold your day and help support your mood. And to encourage patients to do one thing, even if they do it badly. What we don't want our patients who are suffering with low mood during cardiac rehab to do is to wait until they feel better, feel more like themselves, before they return to the things that normally sustain them. Because tragically, that time tends to get longer and longer. And the best time to do this is to do it now, even if it's one very small thing. We need to encourage our patients with low mood to connect with people that they trust, friends, loved ones. Even if it's just virtually, it might not be the same, but it's important and it adds up. We need them to pay attention to their nutrition, even apart from the cardioprotective benefits, that they need to improve their general well-being to ward off fatigue, and also in terms of maintaining their sleep for the reasons I mentioned earlier. Practicing a relaxation technique, much like we touched on in the section on stress, is very important. But techniques like mindfulness are particularly useful for patients who have a more ruminative version of depression. And they're less likely to relapse if they practice mindfulness on a regular basis. It's one of the things that can be helpful. And again, for them to be sparing with the news, their diet of news, because it tends not to be objective and it tends to be quite negatively biased. Again, as was touched on in the opening slides, to encourage patients to obtain psychological support or a mental health practitioner experience in working with depression whenever this is possible. So if you don't already have a care referral pathway, to establish one, to link in with the local mental health infrastructure. This can be done via the family doctor or indeed via the cardiac rehab team. To know that we have very effective treatments for managing depressed mood. CBT has probably been studied the most, but it isn't the only talk therapy. This can be tailored to the individual if they're not suitable or amenable to CBT. And it's important in terms of depressive symptoms that the therapeutic response is monitored, that it's followed through until it's resolved, and that the results are communicated with the cardiac rehabilitation team. I would also encourage patients to find out about medications and whether they might be suitable, and they can do this by working with their doctor. In practice, I find that a lot of patients are quite ambivalent about taking medication or more medication, but in some patients, this is particularly powerful, and it might mobilize their resources to do the things that normally work for them, that they can bring these back into play. And many patients will take antidepressant medication where it's deemed appropriate for them for even a short period of time, and they can discontinue it when things get back on an even keel. If our patients are already on an antidepressant medication, that we would encourage them to adhere, or even to review that with their doctor if it's if they haven't been responding favorably. And that if they're availing of psychotherapy, but also prescribed medications, that we would encourage them to continue with both, because these achieve the best results. And again, it goes without saying that the treatments chosen by patients are all down to both preference and the availability. And just to finish off, I'm going to provide some resources that, again, are available free online and possibly in your jurisdiction, and like online CBT programs such as stress control. And these have been shown to treat mild to moderate depression and anxiety. There'll also be some books and apps that I can recommend. So I've gone over time. My apologies for that. But these are the take-home messages, that, again, there are a variety of feasible strategies that can be employed during cardiac rehab to help patients manage stress and to optimize control over their physical and mental health. That cardiac rehab is an ideal setting to identify patients at risk who may benefit from specialist intervention. And just to reinforce the fact that screening for depression, both pre and post cardiac rehab, is important, but we need to have care or referral pathways available for positively screened patients.
Thank you very much. That is really good, Jonathan, and very practical things that I'm sure cardiac rehab clinicians and practitioners could take to their sites and implement. I personally found it very helpful. 2 points for me. I mean, there's so many good points. I really like practicing gratitude. I think that that is something new, I guess, and I mean, at least to me. And also, one striking thing is the compounding effect of social isolation. I think it's becoming, an epidemic, isn't it? Like the loneliness epidemic. Now we have one quick question, if there's any question from the group, like one burning question to Jonathan. Is there anything? Nope. Okay, so if you have any, if you think of any questions, you can email Global Cardiac Rehab, and we'll kind of liaise with Jonathan, and then for that question to be answered if it's really needing the expertise. But Jonathan will be waiting for the resources, and that you'll be sending us, and we'll put it on our website,
So,
links and things.
yeah, so those resources, one or two of them I need to get permission for, but there's video clips that give a kind of a scientifically based but kind of humorous description of the fight or flight response that patients can find quite engaging. There's a lovely little primer on stress and cardiovascular disease that was updated in Nature Reviews this year. And I have some vetted video descriptions of relaxation techniques and some files that have been modified for insomnia that I'll share as well, that might be useful resources for people to have.
Perfect. Thank you. All right, I will be wrapping up. Can you unshare now? Just be one more minute for me, guys, and then I'll wrap up.
So I need to unshare?
Yeah. Yes, please.
How do I do that now? I'm sorry, I'm trying to figure this out.
can you make me host, I guess, Sophia, if you can, so then I
Yeah,
can
yeah,
share?
I've just changed the setting.
Okay, perfect. All right, so just am I sharing I'm sharing the Kudo slide?
Mhm.
Just to correct, just to correct, Sindh Institute is in Pakistan. So just apologies for him, and thank you for pointing that out. Um, so uh, just a couple of concluding thoughts, and again to echo some of Jonathan's points. Screening for depression at entry and post is really crucial, but also there has to be a follow-up pathway for those that are screening positive. Regarding ICRR participating sites, again, on the whole, we have quite good mental health and at program entry. But I guess the follow-up pathways is key. Quality of life and stress management are high post-program. And the last point is upskilling cardiac rehab staff regarding identifying and managing mental health issues is encouraged. Jonathan touched on, stress management training. If you want to incorporate these strategies in your cardiac rehab staff, so you have to have, I guess, a skilled kind of facilitator for these things. And there is kind of a plug for ICCR clinician certification psychosocial module. So for CRFC. Is that a question, Fahim? Are you raising your
Hi,
hand?
Dion. Yes,
Yeah.
I had a question for Jonathan.
Yep. Just a quick one,
Right.
please.
Yes, yes. Thanks for recognizing us, first of all. And for Jonathan, I wanted to ask you, um, do you have any suggestions for patients who have anxiety and stress because of their comorbids that are apart from their cardiac issues?
Can you give me an example of what you have in mind briefly?
For example, one of our patients was diagnosed with blood cancer and he was undergoing chemotherapy regularly, or another patient who also had Parkinson's. So those patients tend to have more anxiety and stress and depression.
Yeah.
So how can we help them because they already know that they have a long-term condition apart from their heart health and how to manage that?
Okay, that's a tricky one for me to do justice to, and some of that is outside my scope of practice. What I would say though is that in terms of the relaxation techniques that we touched on, they are very broadly applicable and have been trialed in a number of patient populations. And again, I would come back to that sense of, if nothing else, getting a sense of control over your body's physiological reactions. And in terms of, and I touched on this in the slides, if someone was able to do, for example, PMR and diaphragmatic breathing on a regular basis, we know some of the benefits are on the immune system as well. So it's likely to improve sleep, it's likely to improve physiological factors, and that will spill over into those other areas. But again, crucially, that sense of control is quite ubiquitous across conditions. Even a control in terms of how you have your attentional focus.
Right. Thank you so much.
Thank you. Thanks, Jonathan. All right, just a couple more slides for me. Please do join our our ICRR-QI community session. So this is a follow-on from this webinar, and it is confidential, non-judgmental, and this is for sharing within the ICRR community. It's going to be on November 28th, 10 to 11 p.m. I mean, Australian time, Sydney time. And Sophia has already sent the invite. And if you have not, please do email us at globalcardiacrehab@gmail.com. We do have quality improvement YouTube videos, but more importantly, you would have received the ICCPR newsletter. We've released it today, and also we have another exciting initiative, which is the Let's Talk ICCPR podcast. So if you're not in our distribution list, please email ICCPR News, sign up for ICCPR News using this link. It's on our website, so then you get monthly the insider newsletter and the second monthly podcast, at least for now. Follow us on social media, and that's it. Thank you very much, and we'll see you on our QI chat later in November. Again, thank you very much, Jonathan. Very
You're
good
welcome.
presentation, very practical. So
Thank
we
you
really
very much,
appreciate it.
Jonathan. Thank you, Dion.
Take care, guys.
Thanks,
Thank you,
everyone.
everyone
Bye-bye.
else.
Thank you,
Thank you.
Dion. Thank you very much.
Thank you.